Our talk today is going to illustrate why this is such a unique setting. First, over 75% of people would live in low and middle income countries. This map shows the main trafficking flows of heroin. The green is trafficking generated by Latin America, the blue trafficking generated by Myanmar and the Lao People's Democratic Republic, and the pink is trafficking generated by Afghanistan. These trafficking patterns impact many LMICs, and the largest opium production zones are centered around Southern Asia. Historically, this was led by the Golden Triangle of Myanmar, Laos, and Thailand in blue, but it was surpassed by Afghanistan in pink around the mid-2000s onward and is still the largest opium producer today. And so, as you can see highlighted here, uniquely situated between many of these trafficking routes is India. India is home to the largest number of opiate users globally, the second largest number of hepatitis C infected individuals, and the third largest number of people living with HIV. HIV transmission in India is largely heterosexual, but it's also highly concentrated in key populations, particularly people who inject drugs. So hopefully that has kind of set the stage about why global agendas must strive to address HIV transmission among PWID, and why efforts need to focus on low and middle income country settings like India, where the majority of PWID reside. But these populations are very challenging to reach and often have low engagement in care. So next, I want to talk about some innovative approaches that we can use to address HIV transmission, specifically among PWID, but these approaches can apply to MSM and other key populations as well. Given resource constraints and the hard to reach nature of these populations, interventions need to be efficient and ideally capable of impacting individuals in the underlying population that may not engage in care. A promising approach for accomplishing this is leveraging personal networks. HIV is primarily transmitted through sexual and injection partner networks, and transmission is not uniform across the population. These networks include not only people with diagnosed infection, shown in yellow here in the figure, but also undiagnosed infection, shown in red, and uninfected people who are at risk. If we identify these networks, we can work to make sure we're providing testing, care, and prevention to the right people, at the right place, at the right time, and with the best tools. For the most part, efforts to combat HIV to date have been largely focused on individual risk factors. And if you look at the figure on the right, with each ring out from the center, we know less and less. So for example, we know a lot about individual level risk factors for HIV, but comparatively less about how one's indirect network partners, for example, friend of a friend, or what is known as the sociometric network, impact HIV transmission and risk. If we can understand HIV risk in the context of networks, we can better leverage network-based interventions as efficient and effective means for interrupting transmission. For example, key individuals with highly connected networks of injection or sexual partners could represent key transmitters in a population and serve as targets for novel interventions that can propagate throughout their social networks. So you can imagine how an HIV infection in the central node shown in red could quickly propagate throughout the network. Or conversely, how if this individual was on pre-exposure prophylaxis, how an infection in this portion of the network could be prevented from spreading to this other portion of the network. Unfortunately, very few research studies have examined HIV transmission in the context of PWID networks, and those that have typically focused on what are known as egocentric networks. So I want to pause here and highlight a few different network designs to help you see why a network study that we conducted in India is particularly innovative. So the first is this egocentric design, which focuses on an index and their immediate contacts known as alters. So for example, if a patient comes into a clinic or a health program, they might be asked about their sexual or injection partners and asked to provide information about those partners from their perspective. So for example, their HIV status or whether they practice safe sex or shared syringes. What is important to note with this egocentric design is it does not recruit and enroll those contacts. So everything is from the index's perspective, which of course may be biased. And we also have potential missing relationships, that is the sexual or injection partners of those alters, because we don't recruit them into the study. And those are represented by these dashed lines here in the figure. A sociometric design, on the other hand, extends out to indirect contacts of the index. So for example, we recruit the index's contacts, the first degree alters, into the study, and then those alters, and those alters, and so on. So second, third, and fourth degree contacts of that initial index are recruited into the study. This is much more challenging to collect, but this design provides more details and allows us to say much more about transmission patterns and the impact of networks on risk, since we have information about each individual and all of their contacts from their first-person perspective. But for many infectious diseases, there's more to transmission dynamics than just human contact networks, and connections to spaces in particular can be important facilitators of transmission. So we can take that sociometric network a step further and also include spatial ties, for example, injection venues, as a sociospatial network. This provides us a model to jointly investigate the role of social and spatial connections on the diffusion of disease. The role of space can be both direct in the case of fomites or a space facilitating an infection, for example, with respiratory illnesses like TB, but it can also be indirect by representing potentially unknown contacts that an individual may not be able to name or remember. As I mentioned in the previous slide, though, network studies in the context of HIV are extremely rare, especially these more complex designs. So to address this, we created a longitudinal sociospatial network study of people who inject drugs in New Delhi and set out to better understand the network characteristics of PWID and how networks influence HIV transmission and risk. The ultimate goal being to improve intervention strategies for PWID and other hard to reach populations. Recruitment of this cohort started in November 2017 and utilized 10 indexes to initiate recruitment. These 10 indexes were selected from a previous cross-sectional sample that we accrued using ethnography and respondent-driven sampling. And when a participant enrolled in our study, whether one initial 10 indexes or the subsequent recruits, they were asked to recall the names of the people they injected with in the prior month and were asked to provide some information about each of those partners. Each participant was then given a referral card for each of their named injection partners, and they were asked to invite them to participate in the study. When these recruits visited the study site, their information was compared against that which was provided by the index, and if it matched, they were enrolled into the cohort and were in turn asked to do the same for their injection partners in the prior month. We used biometric fingerprint scans to identify duplicates and establish cross-network linkages in the case that the same participant was recruited by two different people. And as part of the baseline study visit, participants completed a survey which captured information on sociodemographics, substance use, risk behaviors, and access to services, among others. And they underwent a blood draw for HIV and hepatitis C testing and sequencing. In addition to injection partner social network data, participants were also asked to identify locations where they had injected in the prior 6 months. And the data that were collected at baseline, including the networks and injection venues, were updated at biannual follow-up visits. So let me kind of walk you through recruitment. This is a slide that was provided by Sunil. And what we did is we start with an index participant shown here as a blue square, and we asked them to name and recruit their injection partners. In our study, we had 10 index participants. So this here, this cartoon represents that index participant's egocentric network. We then asked the recruits, the orange circles, to do the same. And in this example, they don't have any other injection partners. So this also represents the complete sociometric network for this index. The same process happens for another index. They recruit their injection partners, their egocentric network. Then those people recruit their injection partners, those people recruit their partners, and so on. So this would be the index participant's sociometric network. Let's add in another index participant here. And now we have 3 sociometric networks. But imagine one or more of the individuals in these networks share a common injection venue. This would cause the 3 sociometric networks to merge into one sociospatial network, since they're all linked by this common injection venue. I'll add in some more indices here to show that we can also get separate sociospatial networks that don't overlap by any venue. So that's how recruitment proceeds, and but we're also interested in studying these dynamics, the spatiotemporal changes over time. So for example, at follow-up, a participant might report that they no longer inject with the same individuals or report a new injection partner, as you can see here. These dynamics can also cause networks to merge. So what was once 2 separate sociometric networks become one. And the same is true for the sociospatial networks as well. And finally, we can see network ties break and new ties form. And so we want to capture and study all of these dynamics, and that's what we did in this study. So overall, we recruited a total of 2,512 participants. And in terms of demographics, median age was 26 and the majority were male, which is consistent with drug use epidemiology in India. Heroin and buprenorphine were the main drugs injected, with 96% of participants reporting ever injecting buprenorphine and 46% reporting ever injecting heroin. And overall, 60% reported sharing injection equipment. And the median duration of drug use was around 5 years, with a median injection frequency around twice per day. And here is what our injection network in our study looks like at baseline. Each of the circular nodes in this figure represents an individual participant. Colors represent HIV and hepatitis C infection status at baseline, and the edges connecting the nodes represents an injection partner relationship. As you can see from the relative lack of red nodes representing HIV monoinfection and the abundance of yellow nodes, many participants were co-infected with hepatitis C. What's also interesting is that as recruitment continued, the networks of 6 of the 10 index participants we used merged into one larger sociometric network, resulting in a total of 5 discrete components. So it's a little bit hard to see, but here is one sociometric network from one of our index participants. Here we have an index participant who never actually recruited anyone else. Here's another small sociometric network. And then here is this one last sociometric network. All of the others merged into this one large component that you see in the center. So these PWID networks in New Delhi appear to be highly interconnected. And as I mentioned, in addition to an individual social or injection partner networks, we were also interested in spatial networks in the form of injection venues. The study participants identified a total of 181 unique places where they injected drugs in the prior 6 months, and that spanned about a 20-kilometer radius in New Delhi. Here you can see a kernel density plot of HIV and hepatitis C prevalence across these sites. This histogram on the right shows the number of people who report injecting at each location, with each bar representing a different venue. What you can notice here is that one location in particular had over 1,200 participants that reported injecting there. We labeled this venue number 40 in our analyses, and it's located here at the center of the kernel density plot where HIV prevalence is highest. You'll see this hotspot come up again when we get into some of our network analyses. And as far as those analyses go, we started with some basic descriptive statistics and engineered network variables such as path distance using NetworkX and Python. As I'll get into when I talk a little bit about machine learning, networks are very challenging to analyze, and up until recently, we've had to rely on summary statistics known as network centrality measures or specifically engineered variables. You can think of these network centrality measures kind of like mean, median, and mode in a standard data set. They're basically summary statistics that you would encounter. They're certainly useful measures, but they leave a lot to be desired in terms of unlocking the potential and the data that is stored within a network. Baseline HIV prevalence in this cohort was 37%, and 92% of our participants had detectable HIV RNA. Looking at the network figure on the right, of the HIV positive participants at baseline, 65% were directly connected with at least one other HIV positive PWID. So 65% had a HIV positive person within their egocentric, their direct network. But if we look beyond those direct connections, the path length to another HIV positive PWID ranged from 0 to 3, with 0 signifying a direct connection and 3 representing 3 individuals along the shortest path separating 2 nodes. So without even looking at longitudinal data or analyzing risk factors for HIV seroconversion, we started to see that there were patterns related to social network proximity and HIV infection. This told us that community viral load within a network and network proximity to an infected person could impact one's HIV risk, but also conversely, that preventing infections at key points in the network could have wide-reaching impacts on the population that otherwise may not be engaged in care. So next, I want to show you what happens when we consider the role of space. If we take the network representing injection partner relationships that I just showed you in the previous slide and add in venues participants reported injecting at, which are shown here as purple nodes, the 5 separate sociometric networks depicted previously all merge into one large sociospatial network when we account for both the social and spatial ties. This is interesting because it shows us that we're capable of reaching the entire study population when also considering the addition of spaces. This could also be an important programmatic finding, since hosting interventions out of key injection venues could reach the majority of PWID directly or indirectly through the network. The nodes in this figure are, again, sized by the number of connections the node has. So for people, the number of injection partners, and for spaces, the number of people who inject there. And the figure is laid out such that spatial nodes are positioned by GPS coordinates to be congruent with their real-world location. So if they're close together in this figure, they're also physically close on the ground. That is not true of the person nodes, though. The person nodes, the small circles, those are placed using a degree algorithm that basically clusters them off of their social connections. Now here's that same figure, but this time animated to show the social and spatial dynamics of the cohort over time. And the red nodes and edges signify HIV seroconversions. Overall, injection networks were highly dynamic, and 75% of participants reported gaining or losing a partner. But we observed much greater stability in the spatial networks. We followed these participants for a median of 12 months and observed 159 seroconversions before the study was paused in March 2020 because of COVID-19 related restrictions. This equates to an HIV incidence of 21.3 per 100 person years and is sadly one of the highest incidence rates to be reported. Looking at the figure, you can see that many of the HIV infections we observed have connections with a few central spaces, which align with what we saw in the kernel density plot of HIV prevalence at baseline. I also want to point out that spatial networks were much more stable. And if we look at the top venue, number 40, only 9% of participants switched venues. This suggests that spaces may be a much more durable point of intervention for programs. So I want to keep things high level, so I'm not going to spend too much time on this slide detailing risk factor analyses, but what you should understand here is that in analyzing our longitudinal data, network factors were strong and significant predictors of HIV seroconversion, even when adjusting for individual level factors like syringe sharing or injection frequency. The strongest predictor was actually injecting at the top venue, number 40, which conferred over a 3 times greater risk of seroconversion. And this actually extended out to indirect contacts of that location. So for example, every person separating an individual from venue number 40, risk decreased by 26%. So maybe you personally don't inject at this hotspot, but one of your injection partners does, or one of your partner's partners does. For each additional degree of separation you are from that location, your risk decreases. This is interesting because it demonstrates how we can indirectly impact individuals' HIV risk through network connections. The question, though, is what is the best way to do that? Which nodes are best positioned to have a big impact? And that's what I want to focus on for the remaining portion of my talk. The figure on this slide depicts the network structure from our study that I showed at baseline, where each node is a person, but this time it's highlighting the HIV seroconversions in red. Looking purely at the network structure, you can see a large black node flashing at the very center of the network. This person is HIV negative, but you can imagine that if they seroconverted, the infection could quickly spread through the network. In this particular network, this is a very obvious example of a key node that we can identify visually, but usually we need to analyze network structures in more depth, and we'll take a look at that next. I also want to be clear that in an ideal world, we would provide treatment and prevention interventions to everyone. But given the hidden nature of these populations and the limited resources available, this often isn't possible. And even if it were possible, programs still need somewhere to start. And we can use network data to map out the best strategy to achieve the greatest impact. For example, if long-acting treatment or PrEP were to be implemented for PWID in India, it would likely be rolled out in phases. And using network data can allow us to ensure programs achieve the greatest impact, even with a limited rollout. I should also point out that we don't know whether strategies should focus on social connections or on spaces. For example, providing PrEP to everyone who injects at a given venue. So far, spaces are looking much better since we saw less turnover in the spatial networks and the strong associations with HIV incidence, but we haven't actually analyzed the full relational structure of the network yet to know that. And unfortunately, this is where things get complicated. Network structures or any type of graph like a molecule or a 3D shape cannot be fully analyzed using traditional statistical approaches due to their non-Euclidean geometry, which is basically like saying the data doesn't have the correct shape. We can try and map networks to the Euclidean space. We can try and transform the shape, but we typically end up losing data or introduce biases because there's really not any good classical embedding technique. Oftentimes this creates spurious associations and you end up really kind of losing a lot of information. So a main research interest for me is how we can take advantage of the full relational structure of the network for complex analyses, specifically using deep learning. For those of you who are unfamiliar with deep learning, I figured I would pause here and clarify some terminology since these terms are sometimes used incorrectly or interchangeably. Machine learning and deep learning are both subfields of artificial intelligence. Machine learning refers to the use of statistical methods, keyword statistical, that enable code processes to learn without being explicitly programmed. Deep learning, however, is a much newer advancement, and it's the very beginning of mimicking how human brains work by employing artificial neural networks. The key distinction between machine learning and deep learning is that deep learning does not rely on statistical methods the same way machine learning does. Deep learning actually applies a series of transformations to input data that allows it to fit almost any task, which is also why you may have heard people call deep learning models a black box. This is in contrast to machine learning models, which can always be understood statistically. So here's an example to better clarify this distinction. There are certain problems that are difficult or impossible to solve with statistics that deep learning models excel at. For example, in the figure below, you can see some blue and orange data points in a spiral pattern. Building a classification model that can distinguish between these two different colors would be very challenging, if not impossible, with traditional statistical or machine learning methods, since they require a formal mathematical equation. If our data looked like this, however, it would be much easier to do using statistics, but deep learning does not try to find that equation. Instead, it just uses neural networks to recreate a output given a set of inputs. This essentially allows it to fit any distribution of data. Despite this added power over traditional statistics, however, today's modern deep learning toolbox is still specialized for simple Euclidean data types like images or other sequences with a linear structure, for example, speech. But graphs or networks are much harder to process because they're more complex. I'm sorry, is someone able to mute their microphone?
I'll take a look, Stephen.
So I'm happy to talk in more detail about how these deep learning models work if there are questions, but the main thing to understand here is that up until the last year or so, hasn't really been a complete solution to leverage deep learning for analyzing networks. But this solution actually came very recently in the past about year or 2 years or so as a new type of neural network architecture called a graph neural network, or a GNN. This GNN allows us to perform traditional deep learning tasks on networks and represents a major computational innovation that can allow us to understand HIV transmission and better analyze networks to tailor interventions. These GNNs can be used for a variety of tasks, including classification, link prediction, or community detection, which is what we're going to talk a little bit about today. So let's take a look at how we've used this GNN approach to analyze our data from our study in Delhi and inform HIV programs in India. So in applying these methods, one of the first things we were interested in was to identify communities within our network of PWID. In the context of our data, this refers to groups of PWID and injection venues that associate with each other more heavily than other nodes in the network. But this concept can extend to any other type of network data. For example, you can probably think of communities in your own social networks. You have your work colleagues, people that you know from university, or perhaps friends on a sports team. Understanding the community structure of a network is a very useful analysis because we want to make sure that we reach all of these communities with any intervention or education program, since by definition, there's less crosstalk between communities than within them. So we want to make sure that if our intervention is going to have the greatest impact, that we reach all the communities in a network. The results from our community analysis are shown in the figure on the right. This is the same sociospatial network figure of persons and injection venues that I showed you previously, but here each color represents a community, and overall 7 distinct communities were identified. Community number 3 in particular, shown in light blue, is where the majority of HIV incidence was localized. This community also contained the most popular injection venues. We know that we definitely need to reach these communities with any intervention that rolled out. But the next thing that we wanted to know were how these communities overlap. So for example, going back to what I mentioned earlier about the communities in your own social network, you might be able to think of a few individuals or even spaces that overlap your own communities. So perhaps one of your work colleagues is someone that you also went to university with, so they overlap both of those groups. Or perhaps your sports team always eats at the same restaurant as your book club, so those communities overlap at that particular venue. If we can identify how these communities overlap, we can strategically place resources in order to achieve the greatest impact in the most efficient way possible. So we used a method called neural overlapping community detection, which uses a graph neural network to detect the overlap of these communities and identify key nodes that belong to multiple groups. If you're interested in learning more about GNNs and how this method works, I would encourage you to check out this wonderful preprint and GitHub repository linked here on the slide. So here are the results of this analysis. This figure now highlights the nodes in the network according to how many communities from the previous slide the node belongs to. So the gray nodes are only part of 1 community, and the dark blue nodes are part of 6 of the 7 communities. What's interesting is that persons, the PWID participants in the study, typically belong to 1 or 2 communities, but injection venues, on the other hand, belong to several communities, with some key spaces overlapping all but 1 of the communities in the network. So for example, here are a few nodes in dark blue that overlap 6 of the 7 communities. And zooming in, we see that this large square at the center represents that popular injection venue number 40 that we saw earlier. This node is part of 6 of our 7 communities. So disseminating an intervention from this location may represent the ideal way to reach the majority of this particular PWID population. This demonstrates how we can leverage networks and these emerging computational methods to inform HIV programs and identify key points of intervention. For example, with our cohort in New Delhi, disseminating treatment or PrEP at the single venue number 40 has the potential to reach the majority of PWID in this population and offer indirect protection to network members by breaking transmission chains. So instead of hosting an intervention out of several established clinics, we might only need to focus on this one venue and one other in the community that it doesn't overlap. So this allows us to prioritize efficiency while also ensuring that we reach the population at hand. So just to wrap up a little bit here, this study has shown us that networks can be leveraged to improve access to services. To interrupt transmission, we really need to take a step back and look at epidemics through a larger lens, especially with these hidden populations like PWID. And networks are much more complicated than just interpersonal connections. We definitely need to think about indirect connections, the sociometric network, but also connections to spaces and how these all overlap and the interplay between them. As far as next steps with this research, we're currently in the process of completing whole genome next generation sequencing of HIV infected participants in this study. This will give us the ability to examine molecular link transmissions, as well as study HIV phylogenetic and gene diffusion patterns in the context of networks. I also want to point out that leveraging networks can be challenging due to the resource-intensive nature of enumerating them. We actually received a new grant that will allow us to explore network imputation techniques and deep learning and how we can use these methods to make network methods more widespread in settings where these type of data otherwise would not exist. I do have some slides on that I'm happy to share, but I think maybe I'll turn it over to Sunil and then we can circle back if necessary.
Thanks, Stephen. I think after Stephen's talk of deep learning and machine learning, most of you were expecting me to give a talk that's going to look like Terminator Judgment Day or something like that, but you're going to end up with the kindergarten cop version of the same thing. So I think Stephen talked a lot more about the science. It is Pride Month, so I think what we are going to focus more on is the Mithra Clinic. It's an initiative under Accelerate. So I will give you a quick summary. We're happy to talk more about how you use those deep learning methods in programmatic settings in India, but I wanted to switch gears and talk more about the Mitra clinics for now. I think most of you are familiar because I'm seeing from the list, almost all of you have worked in India at some point or the other, or probably are still working in India. So India has about 2.4 million people living with HIV. It's primarily a concentrated epidemic among key populations, ranging from about 6.3% in people who inject drugs to about 3.1% among the transgender communities in India. So I think what is important to notice on this slide is the transgender community in India, despite ART being available since 2004 free of charge in the government sector, the prevalence in this community is still almost 15 times higher than what it is in the general population in India. So I want to give you a little bit of a quick background on what Accelerate is before going into the Mitra clinic itself. So the Accelerate is a USA PEPFAR funded award that we received in 2019, and it's good through 2024. And the goal really is to provide technical assistance to the National AIDS Control Organization and to implement, evaluate, and transition like promising, sustainable, novel models of HIV prevention, testing, and treatment to improve the HIV care response in India and really accelerate progress towards HIV/AIDS epidemic control in India. So we work across 6 Indian states. We manage the entire HIV continuum from prevention and information education counseling all the way to testing, ART retention in 7 high HIV prevalence districts in Maharashtra, which is Mumbai and Pune and Thane, as well as 5 high prevalence districts in Telangana. We also provide services for children living with HIV and orphans and vulnerable children across 33 Indian districts, as you can see on this map, across the states of Maharashtra, Telangana, Andhra Pradesh, Nagaland, Manipur, and Mizoram in the Northeast. And our main partners in the evaluation and implementation of this program are the Vaya Foundation Center for AIDS Research and Education, which is an NGO based in India, as well as Blue Lotus Advisory, who've been helping us with a lot of our demand generation strategies, and the Fenway Institute, who really have been our partners with the LGBT initiatives under this program. We also run a virtual platform called SafeZindagi.in, which is really targeting populations who are in virtual spaces such as Grindr, Tinder, Planet Romeo, and trying to link them with services because this is a population that really isn't traditionally reached through HIV programming in India. So as I mentioned, we have activities across the entire continuum, ranging from rolling out new prevention strategies such as PrEP, all the way to retention strategies such as virtual. We have something called the SVA, which is self-verified adherence, which is a interactive electronic strategy to ensure that people who are on antiretroviral therapy, especially newly initiating antiretroviral therapy, are adherent. I think for the rest of this presentation, I'm going to focus more on some of the comprehensive service delivery models, and one of those models is the Mitra clinic. So the objective of the Mitra clinic really was to establish a welcoming space to the transgender community to access comprehensive healthcare services. I think one thing we have learned from working in HIV in India and other parts of the world over the past 2 decades is really that if you want to reach communities, you really have to take a more comprehensive approach rather than focusing on HIV and using multiple entry points as places where people can enter into services and then leverage those various points of entry to deliver HIV and other essential services for these populations. So this Mitra clinic was established in 2021 in Hyderabad, and it was the first time a community-led healthcare model for the trans community was ever established in India. And this was in partnership with the National AIDS Control Organization, the State AIDS Control Societies, Care, the Fenway Institute, who've been providing technical assistance all along the way, and BLA, who have been providing all the demand generation, especially the posters and the platforms and the messages across WhatsApp and Instagram to try and create more demand for this clinic. So the way we really established Mitra Clinic was providing a much more comprehensive approach to healthcare services. So because it was funded under a PEPFAR program, our goal really was improving access to HIV and STI services. But we realized that there were several other needs that communities had that took almost precedence to HIV services for this community. And so we established this model in a way where you could access many of these essential services that the trans community in India required. And I think one of the areas that was, from our earlier focus group discussions, the areas that really came out as requiring support in which the trans community really wanted to see were gender affirming care, hormone replacement therapy. So that almost forms like the backbone for these medical clinics along with cosmetology. And then we add on to that the HIV, STI services, the general health medical services, mental health services, and the social support services. So I was actually in India six to 8 weeks ago, and I think I had the pleasure of visiting all these 3 medical clinics, and the environment was just full of life and excitement, and everyone really was super excited about these clinics and very happy about the way these clinics were running. And what was really striking was when I asked them in all the 3 clinics, we had one in Pune, one in Thane, and in Hyderabad, what is the service that you need the most? And I think almost everyone said skin lightening and hair removal services, laser hair treatment. And I think when we're thinking of HIV programming, that almost never comes to our mind. We're always thinking about PrEP, we're thinking about HIV testing, we're thinking about STI services, condoms, lubricants. But what was really drawing these clients into these clinics was the cosmetology services and linkages and referrals to gender affirming services. And you can see in the bottom right, there's a picture of a trans man receiving his Aadhaar card, which again in India, to operate anywhere, you need an Aadhaar card, and it gets a lot more complicated. And so we do facilitate registration with the transgender portal in India, as well as essential social support services. I think the other thing I do want to highlight here is during the pandemic, we were also able to provide some economic support. Thank you to everyone who donated through the Gupta Klinsky India Institute during the COVID relief initiative that we ran from here. So I think what I really am trying to say from this slide is, when we are thinking of a program, we need to start switching from a very disease-centric approach and start moving more towards a person-centric and taking a more holistic approach to health. And because it is critical that we take care of health as a whole rather than just focus on one disease, because that is the only way we are going to improve the quality of life of these communities, whether it's the trans community or people who inject drugs. I think focusing specifically on disease is not going to be the answer going forward. It was, and that's where we are right now. It is going to be challenging because you are going to need horizontal integration across these different programs, whether it's HIV or TB or non-communicable diseases. But I think we need to start thinking about how we start operationalizing this as we move forward. So just to give you some quick numbers about the trans clinic in Hyderabad, the Metro Clinic. So we registered about 900 clients. The median age is about 86. Almost all of them were assigned male sex at birth, but about 86% of them identify as a trans woman. About a little over half have completed high school, and about 45% reported engaging in transactional sex. And as you can see, alcohol use is also pretty common in this population, and almost 3/4 of the people who reported alcohol use satisfied criteria for severe alcohol use based on the Audit C. About 11% of the clients who walked into the clinic were already living with HIV when they walked in. And about 20% of the clients who walked in who were not aware of their HIV status had never been tested for HIV before. And again, like I mentioned before, I think the one service that drew almost everyone in was like the gender affirming services, including laser hair removal and skin lightening services. So in terms of the actual services that we provided at the clinic, you can see that HIV prevalence, or the number of new HIV cases that we detected among these clients, was about 7% of the clients who were being tested in this clinic who were previously unaware of their status were being diagnosed with HIV. Syphilis was about 8%, chlamydia was about 4%, and hepatitis B was about 7% of these clients. So you can see from this slide, like it's not just about HIV, but really taking a much more comprehensive approach to both HIV, STI, and viral hepatitis and other services in this population. So I want to end with where we are right now and our way forward. So I think, like I presented the different services we have, and we just recently received a donation for PrEP from the John C. Martin Foundation, where they're committed to provide PrEP for 1,000 trans women in India for 1 year. And we are working with the National AIDS Control Organization to figure out how do we work on the sustainability of this model if it is effective. We also want to focus more on expanding our services, but also reducing costs. because these models aren't free, so people do still have to pay for hormone replacement therapy. And as I mentioned, this was just the basics that we started with. We do want to expand more to non-communicable diseases, expand more towards tuberculosis and other infectious diseases, try and make antiretroviral therapy as well onto the site. So and the Mitra Clinic model really is like a standalone model in the private sector as it is right now. So it is a little bit more on the cost intensive side, but we do want to explore more low threshold models such as help desks within the public sector models, leveraging resources that are already available within the public sector. So one thing I do want to point out is the All India Institute of Medical Sciences in New Delhi is working on this model. And so the Mitra Clinic in Hyderabad almost serves as a model for the country itself. So the staff from AIMS actually visited the Mitra Clinic to see how it was operating. And we've been assisting them with developing these guidelines for these models across the country. The other thing we are focusing on is the sustainability of the Mitra Clinic. So we are exploring different strategies such as cost recovery models where people can pay like a limited amount of funds for their different services and try and see if we can use those costs to actually make these models possible. I think when we started this model, what we really wanted to do is start with something for this community because nothing existed at that point in time. And now that we know that this model is effective and it's really working out well, we really want to start thinking about how do we expand these models beyond these 3 sites across the country. And one thing we are exploring is a collaboration with the Ministry of Social Justice and Empowerment. So Simran really is leading that collaboration. So we're trying to see if we can tap into their resources to try and see how do we take this beyond the National AIDS Program into the Ministry of Social Justice, which is a different ministry than the Ministry of Health and Family Welfare that the National AIDS Control Organization comes under. So it really is heartwarming to like look at the progress that we've made, but I think we still have a long way to go. And one thing we're always looking for is support. And I know through the Gupta Klinsky India Institute, there are several of you of donors who are looking for initiatives to donate to within India. And so any of you who are interested in LGBT health, I think the Mitra Clinics provides like a really great opportunity for people to donate. And you can really see these resources going into the community, as you can see from the results. And our vision really is to ensure that no one is left behind. I know we always say this as part of UNAIDS, but I feel like these Mitra Clinics provide like the first step to a long path that we would need to take to ensure that truly no one is left behind. And we really want to start transforming healthcare delivery from a very disease-centric model, which is what most programs have been, whether it's HIV or TB or viral hepatitis, to switch it more to a person-centric approach to really try and address all the different requirements people have and putting people first rather than putting the disease first. And for those of you who are interested a little bit more, we did have a short documentary about the Mitra Clinic Hyderabad that was made. I have the link on there and we can definitely share the link with everyone at the end. And if we actually have time, we can even play this video for people who want to stay on and listen. So I would need to thank the entire Accelerate team, especially Simran, who took the lead in leading the implementation of these Mitra Clinics, and the National AIDS Control Organization and SACS, and obviously PEPFAR and USAID, without whose support this would not have been possible. And this Mitra Clinic in India really has gotten the attention of USAID and the US government. So this picture on the right is the visit of the Charge d'Affaires, who is the stand-in for the ambassador, the US ambassador to India, who visited the Mitra Clinic and had like great things to say about it and has tweeted about this clinic. So it really has made a big impact with HIV programming itself in low and middle income countries. And I'm hoping that this Mitra Clinic from India not only serves as a model for India, but actually could serve as a model for the rest of the world. So I'll stop there. Thank you.
Thank you so much, Stephen and Sunil. Do folks have questions, comments? Feel free to unmute and speak up if you would like. We got a comment, a question in the chat here. What is the intent of expanding the definition of PWID to one who inject once in 2 years in the eligibility criteria for recruitment?
So in this network study, we were specifically interested in studying transmission. So we were looking for people who were injecting in the prior 6 months, but then their injection network partners were captured in the prior month. The idea being that these are active injectors. These are current relationships that we can use as a model to better understand HIV transmission within networks. Extending that definition in the context of what our aims were would be a little bit challenging, just because it's a bit harder to look at transmission. But for other studies, I think that we could certainly look at that. It just was more tailored towards our aim of looking at transmission.
Hi, Steve. This is Pastor. So I just wanted to understand, was there any understanding of the spouses and the partners of the media units, the non-objective partners? Is there anything interesting that came up in this study?
Mm-hmm.
Mm-hmm.
I'm not sure that I caught all of that. Was the question whether
the question
sexual
was
partners
about
were included?
the spouses of the people who inject drugs and how do they fit in the networks? I think that was the question.
Yeah. So we actually did capture that information. It's not shown in our network figure because generally those sexual partner networks are very small. The people who were injecting drugs, they actually did not tend to have sex very often, just by the nature of these drugs that when you're an active injector, it kind of depresses those behaviors. But we did look at that a little bit, and we just didn't see much of an impact in terms of HIV transmission there. That was also from a egocentric perspective. So we didn't recruit sexual partners into our study. Sorry, we just asked about them in terms of whether their sexual partners were HIV positive, whether they practiced safe sex with those partners, and so on. But one of our big interests is looking at the overlap between PWID and MSM networks and networks of the general population. And for future work, what I would love to do is recruit sexual partners into a study like this, but also look at how these networks overlap between MSM and PWID. In our study in Delhi, we had close to about 30% of PWID report ever having sex with a man. So there's definitely that behavior within this population, and it would be really interesting to see how that impacts transmission patterns across these populations that I think we sometimes think about as more discrete, and it's likely not in that the case. So definitely something that we want to look into more.
Two more comments popped up. Concluding initiating intervention from space as an efficient approach can be influenced by many determinants like availability of drugs, anti-drug drive, can shift at any point in time. I guess more of a comment than a question. And then a clarifying question, just checking whether PWIDs having MSM behavior showed up in your study.
Yeah, so as I said, we had about 30% of people who reported ever having sex with a man. So we did have MSM within our PWID networks. And that's definitely a great point about space. I think space can represent a lot of things like this. Space can represent transient connections, injection partners that one may not name or recall in a study like this. And just exactly to this comment that it can influence many determinants, and teasing that apart is certainly something that we would like to look at in the future. One of our motivations for the sociospatial model is the fact that we recognize that there's more than just social connections, and these spaces do have a big influence. Whether we can say exactly what that influence is, we're not quite there yet. But that's why we model it in this way, and really hope to kind of tease that apart in the future and understand more about these various roles in terms of diffusion of disease in the context of networks.
One other comment that just popped up from David, great presentations representing really creative and important work. question for Stephen. To what degree are you able or planning to examine community collective characteristics as distinct from individual characteristics, such as around social capital, cohesion around collective goals and problem solving, or shared ownership of or access to common infrastructure beyond injection locations?
Oh, that's a really interesting question, and something that we do plan to look at. We did dig into that a little bit in the context of looking at these communities within our network. One of the things that we saw, and maybe I can just put up the slide quick here. In this network figure, these communities are actually largely localized by geography. So the spatial nodes are placed to be congruent with their geographic location. So you can see that these communities kind of cluster around geography. But we dug into the actual characteristics of each of these communities because we were curious what other factors were determining what composes a community. And it's exactly what Dr. Peters was referencing. There's a lot of shared behaviors. There's also communities tend to cluster by demographics. So based off of things like injection frequency, significantly varied by community, age, education. There were several demographic and social characteristics that show that these communities have shared behaviors. So we definitely want to take that a step further in some of our additional analyses, but just looking at this preliminarily, it certainly seems like that's the case.
All right, and I think we have time probably for one last question before we wrap up today. What was the longest distance the study could figure out for network reach?
Oh, that's a really interesting question as well. So this, in terms of the actual spatial venues, they spanned a 20-kilometer radius in Delhi. So we didn't use other methods to really dig into how far these communities can reach beyond Delhi. Within Delhi, it's about a 20-kilometer radius, but some of the other work that we've done with hepatitis C is looking at phylogenomics and phylogeography, which is the study of gene diffusion patterns of a virus. So for hepatitis C, we sampled people from different states across India and reconstructed the phylogeographic patterns of hepatitis C virus to see how the virus moves between these states. And what we found is that Delhi was not a source for a lot of these new hepatitis C infections like one might think, but rather a place where virus seems to pass through. And we found that these diffusion patterns of hepatitis C tended to follow drug trafficking routes. So we really want to do a similar analysis to that with this network study in Delhi, where we reconstruct the phylogeography and also look at networks within other cities to see how exactly, how far can a virus like this diffuse, and how much of that is facilitated by the network itself. So we'll definitely be looking into that in more detail. And currently we're in the process of completing the sequencing so that we can dig into that a little bit further.
Wonderful. Thank you so much, Stephen and Sunil, for a lovely presentation. We were so excited to have you. Wishing everybody on this call and beyond a very happy Pride Month. Take care, everyone, and we'll see you at our next seminar series in July. Have a good one.
Thanks again.
Thanks, everybody. Bye-bye.
Thanks. Great stuff.